we have learned in recent years a lot about genomic lesions that occur in childhood acute lymphoblastic leukemia. So we know pretty well what is happening on the genomic level. However, it has been very challenging to derive or to translate this into like targetable action. And we have, like already 10 years ago, 15 years ago, felt very strongly that we need to develop functional assays to actually fill this gap and take the bridge from the disease characteristics to actually successful treatment approaches. And we have developed such functional assays over the last recent years by using a co-culture system where we actually co-culture primary leukemia cells on top of mesenchymal stroma cells that are derived from a healthy bone marrow. They are immortalized, so we have a fairly standardized assay. So we co-culture these leukemias on these stroma cells that maintains the viability. Can actually culture these cells over weeks in that system. And then we apply different sets of drugs and look at drug sensitivity across many different patient samples and across many different drugs, across different concentrations. And we have developed imaging analysis algorithms together with Peter Horvath to actually specifically evaluate survival of leukemia cells, survival of stroma cells, death of leukemia cells, and death of stroma cells. And this gives us information, sample-specific information for each particular patient sample that we are looking at. And so we feed this information into database and can now actually compare the specific profiles across different patient samples, across different entities. We can look at myeloid leukemias, at lymphoblastic leukemias. And we have learned quite a lot about the biology of this disease when we looked at the first set of around 60 to 70 primary patient samples. And we see specific vulnerabilities to distinct agents that importantly we cannot predict when we just look at genomics. And one example is, and we are heavily working on this at the moment, is distinct cell death pathways that can be triggered with specific agents. So there is an agent called SMAC mimetic that quite specifically activates a non-apoptotic cell death mechanism that's called necroptosis. And there is around 25-30% of all primary patient samples we've been looking at that are highly sensitive to this approach. And we look by using genome editing into the molecular mechanisms that are behind this and could identify that TNF receptors are the key drivers of this sensitivity, because if we knock them out, we actually restore viability despite SMAC mimetic. So we have learned other vulnerabilities, dependence on the BCL2 anti-apoptotic pathway, when we look at the sensitivity to a small molecule called venetoclax. We can look at drug combinations to identify active combinations in distinct leukemias. And clinically highly relevant, we identified a subgroup, in particular in the sub-entity of TALL, that is very sensitive to the tyrosine kinase inhibitor dasatinib, without any genomic lesion that would explain this sensitivity. It's again a functional identification of a vulnerability that could actually be translated. And at this point, we have profiled around up to 90 primary ALL cases in a co-clinical way. and Andre Lissat has looked retrospectively at correlations between our sensitivity analysis in our DRP assay and the response of the patient who actually received either targeted chemotherapy or targeted therapy or, for instance, steroid treatment. And we do see a fairly good correlation between sensitivity in our assay and response in the patient. For instance, steroid-resistant cases are never sensitive in our assay. And we identify the steroid-sensitive cases fairly reliably on our co-culture assay by DRP. Importantly, when it comes to combination, we could actually bridge several patients with a combination of venetoclax and bortezomib to stem cell transplantation. And the bottom line of this is that we actually want to drive this into clinical application in trials where we actually combine molecular profiling and functional profiling in a tumor board to actually guide the patient into predefined treatment arms, so that you can, at the end of the day, apply personalized treatment to the specific patients. And obviously, as new drugs are coming in and we identify more active combinations, the system is really powerful to actually identify active combinations in particular patient samples.